Welcome. I am Dr. Beth Frates, President of the American College of Lifestyle Medicine and Assistant Clinical Professor at Harvard Medical School. Delighted to be here with you today to talk about lifestyle medicine. I'm going to share some slides, and we're going to run through the why, what, how, and when of lifestyle medicine together. We have a few goals that we'll be covering in the next 45 minutes, so we're going to go through some material rather quickly. Delighted to say I will be available for question and answer later in the program. We'll review the past quickly. We're going to evaluate the present, discuss some global advances that have helped get us where we are today, for better or for worse, longevity and trends. What can change the trajectory of the increased obesity and diabetes numbers we're seeing here in the United States and globally? Research on healthy habits. We will talk about exercise, nutrition, sleep, stress resiliency, social connection, avoidance of risky substances, the 6 pillars of lifestyle medicine, and what type of research is behind these pillars. Of course, we have to get on the same page and decide what is lifestyle medicine. I'll share with you the actual definition from the American College of Lifestyle Medicine, and we will cover why lifestyle medicine is different than traditional medicine. Maybe some of you will want to look into becoming board certified. We have an international board of lifestyle medicine, and you may be one of those individuals that will be researching that website later today. Let's talk about the past. Some of you may recognize who this is over here riding a bicycle, where he's thought to have actually consolidated and finalized his theory of relativity. So Albert Einstein out there on a bicycle. Those were the days in the old times when people were out and about walking. Mode of transportation was bicycling. Farming was how people got their fresh produce, and good old-fashioned fun included hula hoops, not the phone or the screen and computer for computer games or video games. Life seemed rather simple. It was hard work, and there was a lot of physical activity, and that physical activity was enjoyable to some extent, and it also was productive, because that is, again, how people got their food. Here we are in the present. We are sitting a lot more, and we are gaining weight. It is an obesity epidemic and a diabetes epidemic. A lot of it's related to our environment here. We have several fast food restaurants on pretty much every street corner that you can find in New York City and other major cities in the United States. And I know that this is a trend globally. I did see this on Nantucket Island, a small island off Cape Cod in Massachusetts, where an individual was in fact walking their dog while they drove the car. This is not the picture. This is off the internet, a free image, but I saw this very thing. And this, I think, really encapsulates the problem. There have been several advances, and we are grateful for them. Back in the Industrial Revolution, 1760 to 1850, the steam engine, the cotton gin, the telegraph, the sewing machine, the telephone, the light bulb, Thomas Edison, all of these advances helped to change the world. Then we had the digital revolution and the information age. This has been a game changer. The original 3 T's, you may be wondering what those are, but transportation, this changed our lifestyle dramatically when we got our cars. The 1908 Ford Model T right there. And then the television, first appearing on the scene in the 1920s, soon dominated American culture and culture globally. No longer were we looking eye to eye with our family members. No, we were sitting around the television looking eye to eye at the actors in that television program. And technology, this looks a lot like my first computer at Harvard College when I was a freshman. I got a computer that looked just like this, and these came in the 1980s. The internet in the 1990s, we had email. This changed the way we could communicate across the globe. So there are some really positive impacts of these types of technological advances, the cell phone, smartphone. Tremendous ability to pass along information and to make progress. There are also some downsides, as you can predict and as you've experienced yourself. The good news is life expectancy has increased since the 1900s. It used to be about 50 years old, and now it's around 80 years old, a little less. And that's in large part due to the amazing health advances that changed the way we live and how we can survive through different infections, through different conditions. So the vaccinations, surgical anesthesia, antisepsis, clean water. Some people still don't have it, but clean water and improved sanitation, antibiotics, antivirals, a birth control pill, improvements in heart surgery, cardiac care, randomized controlled trials came in, radiologic imaging. We could actually find cancers earlier, find problems earlier. This helped our longevity, advances in childbirth, and organ transplantation. There's this quality of life versus quantity. We talked about almost 80 years being life expectancy. Some put it at 77.9 years. And what I want to share with you is that those healthy years are not 77.9. They're noted to be 66.2. So there's some impaired years there. And that's what we really want to avoid. We want to live longer, we want to add years to our life, but we want to add life to our years so that we don't experience these 11.7 years of impaired living. So infectious disease, heart disease, obesity, diabetes, these are all having an impact on our life expectancy. This has changed over the decades, over the century, because in 1900, we were dying of infectious diseases, as you'll see. But then we had our first state house health departments that came in, helped us to control diseases. We got clean water. We had our influenza pandemic. Then first use of penicillin in the 1940s, vaccinations thereafter, and all of the other advances that we shared. So this changed what we were dying from over the past century, 1900 to 1997 here. It was the concern infectious disease, pneumonia, tuberculosis, diarrhea, arthritis. But heart disease and stroke were still there, liver disease, and then there were injuries and cancer. Now back in 1997, you'll see a trend with this as we proceed. The number one cause of death was heart disease, still is today. Cancer, stroke, chronic lung disease, unintentional injury. Pneumonia and influenza went way down the list because of the technological and health advances that I shared. When you look at 2011, so going beyond the 1997 years, you're going to see heart disease, cancer, chronic lower respiratory disease, stroke, accidents, Alzheimer's, diabetes, still influenza and pneumonia. It's still causing deaths. It's still a considerable concern for us. But these are the statistics from the US. Interestingly enough, shortly thereafter, this is from 2011 to 2012, and it is in a report from the American Heart Association in the journal Circulation. You may be familiar with this, and they published this in 2016. Was the American Heart Association saying, these are our goals for 2020. Here we are in looking at results from a survey of 2011 to 2012 around heart disease and its major risk factors. And what we want to do is reduce deaths from heart disease by 20%. And how are we going to do that? Well, let's look at the risk factors and what's well controlled and what is out of control. So the red in this bar graph is poor control. Yellow is intermediate control. Green is ideal control. And then on your x-axis, you have different risk factors for heart disease. Our number one killer. So current smoking, a lot of green, that's ideal control. The y-axis reveals percentage of Americans in ideal control. It's at 87.1% for current smoking. People are quitting, and they're doing so successfully. Then body mass index. Well, we have a problem with that still. So only about 64% of people back in 2011, things have changed in the past decade, and that number has actually gotten smaller, but 64% at this time were in ideal control. Then physical activity, only 38% had ideal control of that risk factor. Now look at this, healthy diet score, 0.5%. This is the area that we really knew we needed to work on back in 2011, 2012, a decade ago. Total cholesterol, blood pressure, and fasting plasma glucose were in really good control. Mind you, we have medications for all those things that are heavily green, these risk factors for heart disease that are in ideal control per the survey. So the idea was we would focus in on lifestyle. We'd focus in on nutrition, healthy diet, and physical activity with our patients. We did try that and we made some gains, but let's look at what the data shows. We're still dying of heart disease, cancer, unintentional injuries, chronic lower respiratory disease, stroke, Alzheimer's disease, diabetes. We often talk about in the US, we have an obesity epidemic, diabetes epidemic, and dementia epidemic. And this is an example of a graph from the US, again, looking at leading causes of death. Here we're looking at 2016, comparing it to 2017 for heart disease. 2016 is the darker blue, the lighter blue is 2017. So heart disease, cancer, unintentional injuries, chronic lower respiratory disease, and stroke still up there as our leading killers. Now let's look globally. This is from 2012. What are we dying of globally? Ischemic heart disease, stroke, COPD, lower respiratory tract infections. So again, number one, heart disease. You may know February is Heart Month in the United States, where we're focusing in on heart disease, and I am reporting this on February 1st. I shall also share and disclose some personal information, which is I am here today because my own father had a heart attack and stroke when I was 18 years old, and he was 52. And that changed my entire world, universe, and career. He did thankfully survive with a lifestyle change. He went to Pritikin Intensive Lifestyle Medicine residential programs. He followed Dean Ornish's work, and I am so grateful that he found the lifestyle medicine pillars and followed them so he could live another 27 wonderful years of his life. And we proceed on with global causes of death, ischemic heart disease, 2016, stroke. The list is very similar. Now, COVID came in and you're thinking, what happened with COVID? Many of you know this data. Heart disease, cancer, then COVID was third in 2020. There were some months, of course, in the US where COVID was the number one cause of death in that month. But overall, when it's been tracked over the year, it was the number 3 cause of death, with heart disease and cancer ahead of it. Now, COVID brought out the importance of lifestyle, and I'll share some data with you. And it also pointed out some discrepancies that we had. Race and ethnicity from this graph, we have 2019 and then 2020 when COVID was factored in. We have total population. The darker blue is the 2019 pre-COVID, and then 2020 is one of our COVID years. We have Hispanic males here on the x-axis, and then Hispanic females. You can see how their death rates increased dramatically with COVID, and then with non-Hispanic Black males and Black females, again, a marked increase in the death rate with Black males and Black females. White males and white females also did have an increase, but we saw a marked increase in the Hispanic population and the Black population. We need to focus in on social determinants of health when we're talking about lifestyle medicine, health care access and quality, neighborhood and built environments, social and community context of each patient, and then economic stability, education access, and quality. All are very important factors to consider. Now, when we think about COVID, we also need to talk about what comorbidities did people have when they were suffering the most severe sequelae of COVID. What they had was hypertension, diabetes, hyperlipidemia, coronary artery disease. Now we know these top 3 are major risk factors for heart disease. So this brings into play how important it is to consider the 6 pillars of lifestyle medicine, which you're going to hear over and over during this conference as well as this presentation: exercise, nutrition, sleep, stress resiliency, social connection, avoidance of risky substances. The data is there. We know that a healthy diet can help people with their immune system. Foods rich in micronutrients like vitamin D, E, C, and zinc, as well as omega-3 fatty acids, may indeed help the immune system. Where can we get these? Of course, vitamin D from sunlight. There's some dairy and soy milk and nut-based milks that are fortified, as well as orange juice, omega-3s from fatty fish and walnuts, and then zinc, shellfish, legumes, nuts, seeds, and eggs, and vitamin E nuts like peanuts and almonds. Sleep. 7 to 8 hours is the recommendation for this pillar. Researchers demonstrated patients who slept less than 5 hours were 4.5 times more likely to get sick than those who slept 7 hours or more. Now let's look at physical activity. We know this is good for us. We know it's good for our cardiovascular health and for our brain health. We know, in fact, that when we exercise, we increase neurogenesis through brain-derived neurotrophic factor. Research tells us this. So this is going to help us with dementia. And we also know that exercise can increase insulin sensitivity, which is going to help us with diabetes. And it helps with heart disease. Research tells us it also helps with our immune function. So 30 to 45 minutes, moderately brisk walk enhances the immune system by increasing T cell function, natural killer cell activity, and macrophage function. Then we get to our risky substances and smoking. We know people who smoked had suffered severely during COVID. So quitting smoking, I like to talk about the benefits, and in lifestyle medicine, we emphasize the benefits of these healthy habits and our pillars. So 1 hour after quitting smoking, you can see a lower blood pressure, 24 hours, decrease in heart attack risk, and 9 months, the myocardial infarction risk decreases by 50%. So this is often inspiring for people to hear. Smokers have a higher risk of developing COVID-19 related life-threatening pneumonia. I want to bring us back to history a little bit here. This is one of the first articles, McGinnis and Figi in 1993, that talked about actual causes of death. We knew at this time, you saw the data, heart disease was our #1 killer. That was the disease we were dying of. But the question is, what's behind that disease? What behaviors are causing that disease? Back here in 1993, tobacco, diet, physical inactivity, alcohol, microbial agents. These are the things that were contributing to death in the United States. Tobacco is the #1 behavior activity contributing to death, then diet and physical activity patterns. Shortly thereafter, one of the articles that really impacted me in my career, JAMA in 2004, Mockdad and colleagues showed leading causes of death in the US in 2000, heart disease, cancer, stroke. Then the actual causes of death, much like McGinnis and Figi, tobacco, poor diet, physical inactivity, alcohol consumption. This was replicated years later by Mockdad and colleagues in JAMA 2018. This time, what was #1? Dietary risks. Our diet is contributing to more diseases and deaths than tobacco use. We need these pillars of lifestyle medicine, one of which is a healthy, nutritious, and delicious diet. Poor diet causes 22% of deaths globally. It's not just a US issue, this is a global issue. We see Central Asia, Eastern Europe, East Asia, North Africa, Central Europe, and globally 22% of deaths. So let's see the 6 pillars. Our recommendations I'll share right here. These are evidence-based guidelines for exercise. Accumulate 150 minutes of moderate intensity physical activity in the week. For nutrition, whole food plant predominant diet, focusing in on plants, which we know when we increase our servings of vegetables, we actually decrease our risk for heart disease. Multiple studies have shown that. For sleep, we want 7 to 9 hours of sleep. Stress management, we know that stress is involved in inflammation, and inflammation is at the root cause of heart disease, diabetes, obesity. And we know that stress, mental stress, has an impact on our hearts. You can see this by EKG. Rosansky and colleagues showed us this back in 1988 in the New England Journal of Medicine. And there's just more and more studies that have shown the same. Social connections and how powerful they are to help us to adopt and sustain healthy habits. And the release of oxytocin is healthful to us It makes us feel good, and it also helps with bonding. And then substance use moderation or elimination. This is all research-based, and I want to hit some of the research with you while we're together. In the Inter-Heart study here, you may have heard of it back from 2004. There's a lot of research and decades worth to share. 52 countries, 15,152 cases of myocardial infarction, and there were 14,820 controls. This reported on the relation of risk factors to myocardial infarction. So what risk factors? You know these: abnormal lipids, abdominal obesity, hypertension, diabetes, smoking. Then psychological factors like stress, like mental health, depression, and anxiety. Fruits and vegetables themselves. If we have low consumption, that's a risk for heart disease. When we increase consumption of fruits and vegetables, we reduce our risk for heart disease. Then moderate alcohol intake and regular physical activity. This is the odds ratio graph that they shared in the report. Everything on the right is a risk factor that will lead you to a myocardial infarction or heart attack, as you know. And then on the left, these are the things that will reduce your risk. So we can see clearly fruits and vegetable consumption is reducing the risk. Exercise is reducing the risk. A moderate intake of alcohol was reducing the risk. The conclusions in this global study: approaches to prevention can be based on similar principles worldwide and have the potential to prevent most premature causes of myocardial infarction. Many people estimate that 80% of heart disease could be prevented through lifestyle changes. Which ones? The ones that we are going to review now, and the 6 pillars of lifestyle medicine, and some that you just saw: intake of fruits and vegetables and regular exercise, quitting smoking. Some of the things that are going to be themes throughout this talk. Here's another study: low-risk diet and lifestyle habits and the primary prevention of myocardial infarction in men. This was a population-based prospective cohort study. It was 20,721 Swedish men between the ages of 45 to 79, and they were examined over the time period of 1996 to 2009, looking at 5 low-risk behaviors. What are they? High-quality diet, so in the top quintile of recommended food score, a moderate intake of alcohol. American Heart Association suggests 0 to 1 drinks for a woman, 0 to 2 drinks for a man. And they say if you do not drink, do not start. There's a lot of evidence that alcohol is linked to cancer. And many people are actually recommending, and you may have heard this from the WHO, there is no safe amount of alcohol consumption now. This is in 2023. This was a research study done a decade ago. They looked at the moderate alcohol intake, they looked at smoking, they looked at physical activity. In this case, in Sweden, walking and bicycling 40 minutes a day, as well as exercising greater or equal to an hour a week. That's what they were looking at as a low risk factor, so a healthy activity to do. And then no abdominal adiposity, specifically waist circumference less than 95 centimeters. And what did they find in this group of men? Watching them over that period of time, over those years. On the x-axis, we have number of low risk factors, number of those healthy risk factors that I just went over with you. And then on the y-axis, age standardized incidence rate per 100,000 person years. And that's the incident of myocardial infarction. So if they had none of those healthy habits, they were the most likely to have an MI. If they had just one, they could reduce their risk dramatically. They added 2, again, a reduction, 3, a reduction, 4, a reduction. But the most significant reduction was when people were able to adopt all 5 of those healthy habits. Now let's look at young people. Healthy lifestyle change and subclinical atherosclerosis in young adults. Coronary artery risk development in young adults, called the Collegesta study. You may have heard about it. In this study, it was prospective cohort study, 3,538 subjects, 18 to 30, followed for 20 years, looked again at healthy lifestyle factors. And what were they? Very similar to what we already talked about: healthy weight, low alcohol intake, healthy diet, physical activity, and a non-smoker. Found out that looking at these individuals over the course of 20 years, they looked at coronary artery calcium score, indicator of atherosclerosis that will be developing in those arteries. Those young people that adopted and sustained high number of those healthy habits had the lowest coronary calcium scores. Those individuals that did not adopt those healthy habits and sustain them, they had the highest coronary calcium scores, most likely to develop atherosclerosis and have heart disease and an MI. We know the risk factors: coronary artery disease, and the lifestyle medicine specialty addresses all of these. And yes, we do use medication. Many lifestyle medicine providers are physicians, licensed and board certified in internal medicine or cardiology, family medicine, and other specialties. And then they go on to get a second board in lifestyle medicine. Medications are helpful and sometimes necessary and indicated. But what we do know from all the data is that when we add these 6 pillars of lifestyle medicine, people are healthier. And in many cases, medications can be reduced and even discontinued. We need this so desperately now because we are in this obesity epidemic. I'm going to share with you some alarming slides. This is the trend of obesity in the United States. So we're going to start in 1990, and I'll bring you all the way up to 2010. Mind you, the lighter color blue indicates states that have an obesity rate, and by obesity, I'm talking about BMI greater than 30. If it's a light blue, those states have less than 10% of their population in the BMI category over 30 obesity. The darker color, that's higher and higher percentage of people with obesity. So 10 to 14% is the middle blue, and then the darkest blue is 15 to 19% of that state has obesity. The yellow changed entirely, a new color needed to be added a decade later. 20 to 25% of that state has obesity, and then the orange, 25 to 29%, and if it's a kind of maroon brown, it's 30% of that population in that state is over BMI 30. Okay, here we go. Starting in 1985, remember the lighter colors are lower, the darker colors represent more percentage of people with obesity. And here go the trends: 1996, 97, now a new color, which is indicating 20% or so. Then we have the red color, and we're into 20 to 24%, 25 to 29%, and then that very dark maroon, which was indicating greater than 30% of that state had obesity. That's in 2010. Then we look over at 2011, and now we're looking at the lowest percentage is 20%, and that's in the green states. Then the highest percentage is the orange, which is 30 to 35% of that state is considered in the obese range. And we're going to go through this for the following decade. And the darkest maroon is greater than 35% of the state is obese. So here we go, just year by year in the US. You can just see, and now we finish in 2021. And unfortunately, there's no blue, very little yellow, and it's all moved into the red and orange category. And here we have 45 to 50% of that state is obese. We have a lot of work to do here in the US. The good news is, in lifestyle medicine, we focus in on the behaviors, and we're hopeful that when we focus in on the behaviors, people will enjoy health benefits and health outcomes in biometrics and in their lab results, as well as their weight, their blood pressure. So in this study, back a decade ago, looked at overweight people. They're the darkest bar graph in this chart here. And then the middle gray is a BMI of 25 to 29.9, so in the overweight range. And then healthy range is the lightest bar graph, 18.5 to 24.9. As you can see, on the x-axis, we have habits, and on the y-axis is hazard ratio. So what's the chance that they will die? Eating 5 or more fruits and vegetables was one of these healthy habits. Exercising regularly, at least 12 times in a month, and then alcohol in moderation, and not smoking. So when people were in the obese category and they had none of these healthy habits, they were most likely to die. Add 1, and there's a marked reduction in their risk of death. And then add 2, add 3, and add 4. So if you could add these 4 healthy habits to people that were in the overweight or obese range, they could see significant benefits. And when they're in the overweight range, that's the middle bar, they are going down, 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 and the benefits of adding a healthy habit continue until they get to 4. And that is what we're striving for. Interconnectedness of COVID and lifestyle, COVID and obesity really brought out the importance of addressing this. And worldwide obesity has nearly tripled since 1975. It's not just a US trend. It's important to take a look at this throughout the world and in children, which has been in the press recently. Here's Europe, just so that you can see Europe's BMI rate for greater than 25, overweight, 53% of the population. This is for the European area. Specifically in Ireland, where I was called in to do some help in helping for medical education there in the Royal College of Surgeons, Ireland, Dublin. I was struck by this prediction and graph that they had in their Irish Times. And it is the percentage of the population who are obese. Men are blue, pink are women, and they projected a very rapid escalation of obesity, and that is what happened. Now we have to talk about diabetes. This is the United States, and this is per county, and it is the percent of people in the county that are diagnosed with diabetes. It starts in 2009. You're going to see a very similar trend to what you saw with obesity. This is 1958 to 2015. So what has happened with the number of people with diabetes? It's in the blue line, and the percentage is in the yellow line. We look back at years on the x-axis, 1958, and we see a rapid rise in the diagnosis of diabetes by number and by percent all the way to 2015. There are similar graphs that you have seen with obesity, and they mimic the same thing with diabetes. It's really astounding. You saw this with obesity, and then let's go and look. Here we go by county with diabetes. 2004, 1.5 to 6.9% in the light blue of those counties had people with diabetes, and then the darker the color, the more the population diagnosed with diabetes percentage-wise. As you can see, the graph has gotten darker and darker as the years have gone on. We have a lot of work to do, and we know what we can do. Research has shown us. This is a great study, reduction in the incidence of type 2 diabetes with lifestyle intervention or medication, metformin. What do we see? Diabetes prevention program. This is a landmark study. You may have read it in 2 decades ago, 2002, New England Journal of Medicine. 3,234 non-diabetic patients with elevated fasting and post-load plasma glucose levels, so we call them pre-diabetic, randomly assigned to placebo, metformin, or lifestyle intervention. What was a lifestyle intervention? Lose 7% of initial body weight through a low-calorie, low-fat diet, achieve 150 minutes of moderate intensity physical activity per week, and then there was some education and coaching involved. 16-lesson curriculum covering diet, exercise, and behavior modification, behavior change. This was taught by case managers. It was flexible. There were some individualized one-on-one sessions as well as some group sessions. Sure enough, over the course of 4 years, they looked at the cumulative incidence of diabetes on the y-axis, years are on the x-axis. And if we look here, we can see that lifestyle, that intervention, was 58% more effective than placebo at reducing the rate of conversion from the pre-diabetic to the diabetic. These subjects, remember, were all pre-diabetic. Metformin did pretty well, 31% reduction compared to placebo, but what did best? Lifestyle. Lifestyle, those factors that we've talked about over and over today, did better than metformin. The nutrition, the exercise, these 2 big pillars that we have. but we have 4 more, and those are critical as well. Here's another study, landmark study, back 2 decades ago. This is when the American College of Lifestyle Medicine was originally founded. All this data was mounted, and it was time to create a specialty society for physicians and other healthcare providers to learn what they didn't learn in medical school about nutrition, exercise, sleep, stress resiliency, social connection, and avoidance of risky substances. A lot of data around diet, especially from Dean Ornish. This one is the portfolio diet compared to a statin and control. Again, is this as good as medication? Well, in the portfolio diet, they substituted soy foods for meat and dairy. They maximize sticky fiber. We know we're fiber deficient to this day in the United States and even globally. And that's oats, barley, eggplant, okra, and then plant sterols and almonds. And those people that follow the portfolio diet, if you look, compare control, statin, and the green is dietary portfolio program. The red is the statin, yellow is the control. And if you look over the course of the 4-week program, the control, they reduce their cholesterol level. Percent change from baseline is on the y-axis. Weeks are on the x-axis. The control did a little bit better. But look at the statin. Of course, as you predicted, it did very well to change the percent of cholesterol. And then look at how well dietary portfolio program did. Just about as well as the medication. So we do use medicines in lifestyle medicine. Yes, we also harness the power of lifestyle changes. And we know how powerful it is by research. This is from 2018, looking at high blood pressure, one of our major risk factors for heart disease. We know if you lose weight, you can see changes in blood pressure. So your systolic blood pressure can go down 5 millimeters of mercury, 5 points, with a healthy diet. Dietary approaches to stop hypertension is one such diet that is whole food, plant predominant, plant slant, and that can reduce blood pressure by 11 points. Of course, reducing sodium is critical for people with high blood pressure. We should be recommending this all the time, and that can reduce your risk of heart disease and by reducing your systolic blood pressure by 5 to 6 points. Now, increasing potassium is critical, and that can improve systolic blood pressure by decreasing it 4 to 5 points. Activity, aerobic activity, dynamic resistance training, isometric resistance training, all can reduce our systolic blood pressure by 5 to 8 points, 4 points for dynamic resistance, and isometric resistance is 5 points. Alcohol consumption, in this case, less than 2 drinks for men, less than 1 drink for a woman. Again, 0 to 1, 0 to 2, looking at 0 these days and evaluating this one, but that was lowering blood pressure by 4 points. So what we do know is that a reduction in just 5 millimeters of mercury in systolic blood pressure has been found to be associated with mortality reductions of 14% from stroke, 9% from heart disease, and 7% from all-cause mortality. So utilizing these pillars that we just reviewed can make a significant difference in terms of risk for heart disease and stroke and mortality reduction from stroke and heart disease, and all-cause mortality, 7%. Something we didn't talk about, this is our stress reduction pillar, practicing yoga, meditation, mindfulness-based stress reduction programs, Tai Chi. Any other movement activities combined with deep breathing will alleviate stress, and that in and of itself can reduce blood pressure. And mindfulness-based stress reduction programs, which is created here in Massachusetts, University of Massachusetts by John Kabat-Zinn, found that blood pressure reduces from 154 points to 138 points after an intervention. So lifestyles medicine, we need it. We need it today. And the definition, here it is. Lifestyle medicine, medical specialty that uses therapeutic lifestyle interventions, all of which have been researched and recorded. And we shared some of the major landmark studies as primary modality to treat chronic conditions, including but not limited to our number 1 killer, cardiovascular disease, type 2 diabetes, and obesity. We have an epidemic. Lifestyle medicine certified clinicians are trained to apply evidence-based whole person prescriptive lifestyle change to treat and, when used intensively, often reverse such conditions. Applying the 6 pillars of lifestyle medicine whole food, plant predominant eating pattern, physical activity, restorative sleep, stress management, avoidance of risky substances, and positive social connection also provides effective prevention for these conditions. Check the ACLM website for more information and even more data and research. Here is just a graphic of our 6 pillars. Hopefully you're familiar with them by now. Past President Mark Brayman, he was president of the American College of Lifestyle Medicine back in the 2010-12 range, and he created this. Yes, we need surgery. We need prescriptions. We need medication surgery in some cases, absolutely, to keep people alive and thriving. But there's also low-cost ways that we can help reduce the risk and help treat and maybe even reverse some of these conditions like high blood pressure, like diabetes, like obesity, if we use lifestyle medicine. And that's working with our body's physiology. So the field of lifestyle medicine, I told you American College of Lifestyle Medicine was started in 2004. It recognizes the link between lifestyle medicine, health outcomes, between behaviors and health outcomes. And we use the science behind behavior change. So yes, we need added skills. We need to learn how to use motivational interviewing, how to use the coach approach. We may have the knowledge around the guidelines and around the research. We have to convey this to the patients in a way that is empowering so that they will be motivated to adopt and sustain these changes. It requires a new skill set, not just selling and telling about what to do and what not to do, but to collaborate, negotiate a plan, a SMART goal, specific, measurable, action-oriented, realistic, time-sensitive, around these lifestyle changes that will support their health. There are competencies for prescribing lifestyle medicine that were reported out in 2010 in JAMA, and these were then updated in 2019. I recommend you take a look at those, and we talk all about what assessment tools we need, how to build effective relationships, how to work in teams, because we do this with nurses, with health coaches, with dietitians, with physical fitness experts, physiologists, with sleep experts, and with others. And we may need to make referrals to psychiatrists, psychologists, if indeed depression, anxiety, and stress are things that are holding people back. And we use medical information technology, promote healthy habits as the foundation for health. Yes, indeed, we may need to prescribe, if we're physicians and practicing this, prescribe medications. If we're nurses or health coaches, then the patient may be under the care of a physician that is prescribing medications. But we're doing everything we can to utilize our 6 pillars to help people reach optimal health. I do recommend you look at these updated competencies when you can. And I will share with you some valuable resources you could use today. So this is the LM 101 syllabus that I put together and shared through the American College of Lifestyle Medicine. It's been available since 2017. We're going to update it this year. It has over 5,000 downloads from over 100 countries. Then there's the LM 101 curriculum, 13 modules that follow the Lifestyle Medicine Handbook. All my proceeds go to the American College of Lifestyle Medicine. You can download this LM 101 curriculum for free. It's valued at $1,500 or so, and it can be used at a master's, doctorate, health professional education level, bachelor's level. I know medical schools are using some of the PowerPoints to teach their medical students and residents, and many people use it in their CMEs to help educate around the 6 pillars. There's understanding lifestyle medicine, the coaching, empowering people to change, collaborating, motivating, goal setting, tracking, improving health through exercise, nutrition, health connection, weight management, sleep matters, stress and resilience, peace of mind with meditation, power of connection, positive, looking at positive psychology and how to use that. And then substance use disorders, and then staying the course, because this is a journey. Lifestyle medicine is a journey. I've been on it since I was 18, and you know my motivation. Here is what we need to learn more about: collaborating and coaching patients. You need to know the guidelines and the research, but then you need to know how to put it into practice. I suggest you look at this article that I put together in American Journal of Physical Medicine Rehabilitation back about a decade ago, when I became a certified health coach and did a lot of motivational interviewing. I have taken 5 or 6 health coach training and behavior change programs now, and I like to share my knowledge widely. It's not just one-on-one counseling we have to do. That is important, but there's the social, ecological model of change. We need to think about the relationships around the person, the community around the person, the society, the laws around the person. So the individual behaviors are important, but what's around that environment that circles the individual? We need to think about their family structure, their workplace, their neighborhood, what's available for food. Where can they get produce? Can they have their own garden? What is safe for them in terms of walking? Now, we get this into medical schools here. It's very important. So we have lifestyle medicine interest groups, which are parallel curriculum I've written about in Clinical Teacher. You can look that up. And we started this at Harvard in 2008, had our first one going in 2009, and now there has been a great growth of lifestyle medicine interest groups in medical schools as well as other healthcare professional schools. And the American College of Lifestyle Medicine can help you set one up. They're at Harvard, Brown, Emory, Howard, Mayo, Loma Linda, Michigan, Ohio, all over the United States. University of Hawaii has one, Yale, Cornell, University of Vermont. They're everywhere. They're going to pop up. There's 200 medical schools. Our goal is to get one of these lifestyle medicine interest groups into every single medical school. If you want to get funded for this in Finland, you can go through the Donald A. Pegg Award. Actually, my family created this award upon my father's death to try to help people and medical schools and the next generation of medicine to learn how to use lifestyle medicine to adopt and sustain healthy lives so that we could reduce our risk of heart attack and stroke. So you can apply for that too. At ACLM, we're also working on lifestyle medicine residency curriculum. I'm teaching this at Harvard to the Ahmed residents. It's got 40 hours of didactic material, 60 hours of application activities, and you can go ahead and use that as well, that resource, and look into that through the American College of Lifestyle Medicine at this website right here. We've been going strong since 2004. Dr. John Kelly was our first founding president. And actually, I just co-authored an article with him for my next From the President's Desk in the American Journal of Lifestyle Medicine. I hope that you do take the opportunity to read that. I talk about intensity and dosing of lifestyle medicine in that. And we are growing rapidly. We are at 9,500 members strong. You may be familiar with some of these past presidents like Dr. David Katz, remarkable group of individuals, and we are building on their strong foundation. ACLM's created 2004. We have the JAMA article 2010, the American Medical Association resolution saying that we need to get lifestyle medicine into practice and into medical schools. ABLM, American Board of Lifestyle Medicine, is formed. I was one of the 4 first physician writers, item writers for this exam in 2017. There were 4 of us. We created the exam. And now we're updating the exam. We're going to be an item writer for that as well. I'm very much looking forward to that. I love academics and getting into the details of this. There's also a specialist fellowship and specialist training, and we have maintenance of certification, which was introduced a few years ago. If you're thinking, what are the core competencies? You know them because I've just reviewed in this literature and research presentation today what's important. Fundamentals of health behavior change, clinical processes in lifestyle medicine, role of the physician health and physician's personal health. Nutrition is a big part of it, 26%. Physical activity is 14%. Emotional and mental well-being is 10%. Sleep, 8%. Managing tobacco cessation, other toxic exposures, 8%. The role of connectedness in positive psychology, social connection, 8%. So yes, there are some new skills that we will have to acquire if we want to be certified in lifestyle medicine. A lot of it is behavior change. A lot of it is new, and that's in the nutrition realm, physical activity, even positive psychology, connectedness. We didn't learn this in medical school. So we have CME for you available at ACLM if you want to learn more. There's 2 different ways to get certified: the experiential pathway, the educational pathway. You can look at the American Board of Lifestyle Medicine for details on all of this and its requirements. There's the International Board of Lifestyle Medicine, and these are just some locations where the board exam has been given, and there are diplomates in all of these different areas around the world. This is a global movement, and now is the time. Finland is going to get on the map. I'd be delighted to help you. We are increasing in our numbers of board diplomats in the International Board of Lifestyle Medicine. That ends my talk, and there are several references that you'll be able to look through. I do recommend you go to the American College of Lifestyle Medicine. In the research arena, you will see more and more data there, and you could also get the Lifestyle Medicine Handbook, which I am a co-author for. Thank you so much for your time. I hope it was helpful.